Yeah, that's fine.
This session is presented by Wellcome Collection, and Ashok has something to say about the Wellcome Collection. Ashok, if you can do the...
Good afternoon. The Wellcome Collection is a London-based museum that explores the connection between medicine, life, and art. The Wellcome Collection is part of the global medical research charity, the Wellcome Trust. The Wellcome Collection puts on exhibitions and events that explore healing and medicine in their broadest cultural contexts. At the moment, the Wellcome Collection is behind an exhibition called Tabayat, Medicine and Healing in India, being held at the CSMVS Museum in Mumbai. The Wellcome Collection also works with publishers to produce books. These three authors are all part of the Wellcome Collection book publishing program and have all written about medicine and healing, approaching it from very different angles. A very good afternoon to you. I have three, as we said in the blurb, three very distinguished people here. I would ask each of them to give us 2 minutes, a 2-minute intro. Aarthi, Prasad, if you would like to start, please.
Hello, I'm Aarthi. I live in London. I trained as a molecular geneticist. I did research into cancer, and then I started working in science policy and communication in UK Parliament and making documentaries for TV and radio in talking about science, but science that has a social context, and that's what I'm interested in. And now I work at University College London, and we facilitate interdisciplinary research in the area of well-being. So we look at the social determinants of health as well as the medical.
Next up, we have Gavin Francis, who's a physician from Edinburgh and an author.
Yeah, that's right. So I am a doctor practicing in Edinburgh in Scotland, and about half the week I work as a doctor and half the week I write. But before I became a doctor managing that kind of balance, I was a travel writer, essentially. My first couple of books were about landscapes and history and culture. And when I am approaching this session and these ideas in my own books about healing and what well-being is, I think it's useful to come from a couple of different angles. So the word physician, as you know, it's a Greek word that's to do with nature. It's that old idea of the doctor as being somebody who's very engaged with natural science, natural philosophy, and that's something I think that we've lost to a certain extent, and I'd like to try and reclaim that, and I try and explore that in my own books. And also the idea of being a healer, healing is healer and heal health. That's an old German word. It's to do with wholeness. It's like that old WHO definition of health as being the social and the physical and the mental well-being and not just the absence of disease. And I think that's what my own essays try and look at. They try and explore the idea of the doctor and the health in the context of the wider world and nature and culture, and also the idea of wholeness. The doctor is somebody who tries to bring people to a sense of contentment and ease with their environment and ease suffering.
Thank you. Thanks, Gavin. Next up, we have Atul Gawande, distinguished physician, surgeon. I will leave Atul to explain.
Yes, I have a few hats I hopefully get to wear here today. I'm a surgeon at the Brigham and Women's Hospital and in Boston. I'm a professor at Harvard Medical School and Harvard School of Public Health. I've been lucky enough to be a writer with The New Yorker since 1998. And also relevant is probably the fact that my family comes from two different parts of India. My mother, who's here today, is from Gujarat in Ahmedabad. She was a pediatrician, met my father in New York City, who's from Maharashtra, who's a surgeon, and they married in New York City. I was born there, raised in Ohio, and came into writing very late in my career during my surgical training. I also run a public health research institute at Harvard called Ariadne Labs. So that's the compass.
Thank you, Atul. Okay, so we have an incredibly interesting topic here. These are all healers with me of various sorts, and we're trying to explore the differences and the similarities between Eastern methods of healing and Western. Essentially, that's what we're trying to get at, and we'll throw it open to the audience in the last 15 minutes. So if you have a question, get ready. It's a topic that everybody has a very definite idea about. It's rather like politics or religion, and no two people will ever agree. First of all, I'd like to ask you all to explain, in your words, to us lay people, the differences in approach that you see between Eastern medicine and Western medicine. Aarthi?
I'm not a physician myself, so I'll probably leave that to the other two, but I spent the last year traveling around India, collecting stories from different socioeconomic groups and different systems of medicine to try and understand how people approach their health and why people make the choices they make in the types of medicine or the doctors that they choose. In India, it can be quite complex because people who would be considered outside of conventional medicine and people who are in conventional medicine, sometimes there's a little bit of an overlap. But there are also distinct differences that are often quoted, and that is that alternative medicines, what we call CAM, or complementary and alternative medicines in the UK, are typified by the amount of time the doctor spends with the patient, the holistic approach, and a sense that the doctor wants to know about the life and the family and the wider unit, maybe the children of the person, you know, the sense of where they live. Whereas with a conventional doctor, there tends to be a table in front of you, drugs are given, it's not very well understood, and the thing that comes up over and over again is there are side effects. The alternative medicines don't have side effects. That's not necessarily true, but that's the perception.
Gavin, how do you try and counteract this time business where? Well,
I think that the Western medicine, I mean, modern Western medicine has been phenomenally successful worldwide. And wherever you go, if you're really ill, with a microbial illness, if you've got certain kinds of malignancies, if you've got lots of very complex somatic, very physical illnesses, Western medicine has been tremendous. And in India, I travel around, you see signs that say English medicine every so often. Yet, we've been kind of lulled into a sense of security because of that tremendous success. And so the time has got shorter and shorter and shorter because there's this misperception, actually, that you can treat all kinds of ill health or lack of well-being in a very methodical way, a very protocol-driven way. But many people, of course, have very complex problems with their health. They have perhaps, all to do with their environment, to do with their context, to do with the way they're brought up, their unhappiness. Their wider social health, of course, isn't amenable to that kind of quick fix solution. And we learned a great deal from the Enlightenment, from Descartes, from this kind of idea that the mind and the body are extraordinarily separated. But we've kind of realized that's not enough. It's not good enough, actually. We need to involve the environment and a much more holistic attitude much more. And in the West, complementary therapists can do that because it's a private system, because you pay for the time, so you can pay for as long as you want with the individual. The pressures on the Western medicine, which is socialized medicine, as you know, the National Health Service is very different. And so I would like to have more time with my patients, but I recognize that it's taxpayers' money paying for my time, and so that's got to be balanced with the effectiveness of the care that I provide with that time.
I'd just say that's really important what Gavin just said. One of the key differences, I think, is that lack of separation between body and mind in Eastern systems of medicine. That when you are displaying a symptom, they try and understand what's happening to you in general. Whereas I feel like in Western medicine there is a difference, because I work a lot with psychiatrists. There's the body and there's the mind.
And they're quite separate.
Yes.
Yeah.
The idea that you could take a mental health problem and see it completely in isolation and say, oh, there's something to do with the way your brain works is crazy. We all know that's crazy. We know that mental health problems are extraordinarily complex and extremely environmental. But we don't have the time to sit and unpick all these things, and so that's why people end up getting prescribed Prozac.
Atul, you practice in America, which is generally held to be at the cutting edge of all things medical and scientific. What is it like there? How do you try and reconcile this body-mind?
East and West.
East and West.
I'm very resistant, and I suspect you all are too, to trying to generalize about it. And so it makes me want to go to the particulars. And I'll go to one event that was an incredibly shaping event in my father's life, that his mother died when he was about 11 years old from malaria in his village in India. And he watched her die over the course of 6 weeks from a treatable disease. This was during the 1950s. Late 1950s, so it was a period of time when there was the possibility that there were medications available worldwide, but he's in a rural village. He'd never seen a doctor in his life. They turned to Ayurvedic medicine, they turned to the local shaman, the local healer, and he would go. The family was poor, and so the shaman would not necessarily come, but he agreed to teach my father, and so he would put his hand on her pulse and feel it, and he was being taught how to feel what is happening through the pulse, and he felt that he could not feel it, that he could not feel where the solution was that would save her life. And he had also, I don't know how, heard that there were treatments out in the world. And when she died, he wanted to become a doctor. He'd never met a doctor, but he'd heard the word doctor, he knew it was different. And I'd say there was some sense in which now, even in going back to the same village where my father grew up, there is that mix, that people turn to Ayurvedic medicine, to other kinds of healing rituals around critical illness, but they're very aware. We have 13,000 ways the human body fails. We've now generated more than 6,000 medical treatments, more than 4,000 medical and surgical procedures, and people want to have access to that world storehouse of knowledge. They're not saying, don't give me that. They turn to the traditional healers, but they don't expect it to do everything. They don't see it as either or. They want to see that they have the whole package available, and they feel acutely that they're deprived of it, that they are deprived of those other components.
Yeah. Why is there this connection between medicine and religion? And medicine and magic also, but let's deal with religion first. What do you think? Why is it that there has always been this connection?
I was going to pick up on something Atul was saying, that you kind of get a sense when you visit conventional doctors versus doctors from other systems, that doctors in other systems tend to say they know what you've got and they can heal you. There's no doubt. There's no doubt. It's almost like they don't have doubt, and people, maybe it's a human psychological thing. Yeah, I see less doubt. So when people go to them and someone says to you, if you've gone to many conventional doctors and they say, I don't know what you've got, and you go to a healer and they say, yes, I know what it is and I know how to heal you. What you find still, what you're describing is people in rural settings who don't have access to hospitals or conventional medicine necessarily. When I was traveling in the last year, I spoke to people, auto drivers, taxi drivers, the laborers who work on building new structures, very poor people. And I said to them, do you go to Ayurvedic clinics? Do you go to Unani? And they said, no, madam, we go to the clinic. There's about 20 in the town. They just choose them by which clinic is more affordable, and they know that. So it's something aspirational. Whereas you have people in the sort of upper economic classes who make choices to use Ayurveda and other medicines as a kind of reorientalized lifestyle choice.
Yeah. So there is this kind of cross thing where people who would normally be expected to go to Eastern medicine look towards Western, and there are a growing number of Western patients who are looking eastwards.
Yeah, and they see it as being more effective.
Yeah.
And fast acting. That's the thing.
Often it is fast acting. The drugs are very powerful and to do all sorts of things, sometimes too powerful, which brings us back to the side effects thing. I want to make what you said about magic. Sigmund Freud was very good on the subject of doctors and magic, and he said a brilliant line, which was that all doctors, he said, are continuously practicing psychotherapy. All of you, just by the very act of consulting, that is a therapeutic process. And so as a doctor, you should try to take this factor and make use of it. Understand that the effect of your interaction with the patient itself is therapeutic. And I think that is something that Western medicine, particularly the way I was trained, was kind of ignored, really. I mean, it used to be called just bedside manner. They would say such and such doctor's got a good bedside manner, which kind of, it dumbs it down a bit. It says you're just being polite. Actually, what you're trying to do, as you say, is inspire confidence in people. That is a kind of magic in a way. You can cure people through inspiring their confidence and their faith that they can get better. Yeah. And that's what he was trying to get at, I think.
And what I wanted to add is, when you look at why people use medicine that's not conventional medicine, it tends to be for things that conventional medicine can't cure, or that they have a chronic condition for which there is no relief in conventional medicine.
I think that ties into, though, I mean, I see religion, and not just magic, playing a certain role. Number one is that there are certain things that are in our control, and there are certain things that are not in our control. And people turn to religion to cope with, importantly, the things that are not in your control, and hope that the forces out there that can provide some shape and some direction to the things that seem to be out of human control, that, you know, they might line up in the right directions. I have certain prayers about how my sports team, the Boston Red Sox, will do this coming season. It's not in my control as much as I feel like it's in my control. I even have, you know, these rituals that if I'm watching and they're ahead, if I keep watching, that they will fall behind. And I know it's not rational, but it is, you have these associations. And I think the second part of it is that what happens in our bodies is invisible, and many of the things that we use to act on our body may be scientifically established, the role of a vaccine, but at some level, it's magic. You know, this thing is magic. It gets beams of light coming in, and somehow it makes stuff happen. And to me, it's a kind of magic, and it's not surprising. You know, in the polio campaign, we were dealing in the north with people feeling that this vaccine was a deliberately targeted intervention to sterilize Muslim boys, and that it was a kind of magic force because it was not explained, and it was credible that it could be used otherwise. And we have a similar anti-vaccine movement in my own suburb, where you have very well-to-do people who are highly educated, who believe the vaccines are causing harm, and the result is we're seeing our first outbreaks of conditions like whooping cough and measles that we've not seen in decades. So it's the invisible, and it's also what's in your control and what's not in your control.
I had a question when I was going through looking at different types of doctors of medicine, which is that, do we really need to know or understand how medicine works for us to seek that out? Because in a normal setting, I don't know how many of your patients come to you and say, what's the evidence for that, or how does that work?
I think they might not need to know how it works, but they have to have faith that it works. And so this is why they call it...
Yes, that's precisely it. Is it blind faith, or is it researched faith?
I'll tell you a story about doctors in medicine and this priestly role. Doctors are increasingly taken in our society, which kind of worships medicine in a way. And having this priestly role. I had a patient whose wife died tragically, and who was really struggling with grief, and months went by, and I would see him about various problems, and also always ask how he was doing, and he was doing very badly. He was slipping into a kind of an existential crisis, really, about believing that his life was futile. He was grieving, and he asked me for help with that, and I knew that he was a very devout Christian. And so I asked him, have you discussed this with your pastor? And he looked at me and he said, I think that sort of thing's better left to the professionals, don't you? and I, well, you know, you have a profound faith, and your pastor is a professional in questions of the spirit. But our society, in some ways, Western society, has moved so far to the idea of doctors being in this priestly role, that someone having an existential crisis goes to a doctor instead of a priest.
Instead of a priest, yeah.
It's usually a bad sign when your doctor recommends you go see the pastor.
No, I disagree. I see a lot of people with spiritual crises, and I think they do need a pastor.
Well, they take it that way, though, right? So
Yeah,
you have to have an explanation before you write the prescription.
Yeah, absolutely. Yeah.
Now, has the Western healthcare system, which deals with everyone, I mean, in any particular country, not particularly India or UK or US, is it in some way beginning to fail? Because you have this one-size-fits-all kind of thing, and many governments are finding that they cannot afford, the national health system or whatever, cannot now afford to continue. Is this why there's more of a prevalence of magic? Or am I wrong here in saying that?
So I don't know that there's more prevalence of magic, or I think it's just never gone away, that there's a level of superstition and then there's a level of turning to God. And I think Gavin's right that at some level, as we've medicalized, we've consigned the spiritual to a narrower corner of the picture. But I think that the larger sense of it is that when we have now reached a place where there are very few conditions for which healthcare cannot offer something to reduce your misery. We can't cure everything, obviously, but even in metastatic cancer, for many incurable conditions, we can reduce your suffering, we can provide ways for intervention. Now, matching that to what actually matters in your life, there's often a disconnection between what your priorities, goals, and values are and what the medical view of it is. Medicine assumes your primary goals are health and survival, instead of understanding that your primary goals are bigger than just health and survival. It's well-being, and well-being means sometimes you're willing to sacrifice your physical health for other goals, like being with your children, being at home, accomplishing certain life projects, and trying to match what those capabilities are with those things that are most important to you. I think we often fail, and that's where suffering and a feeling of disconnection, anger at the system, it also is a source of driving costs, because we will test and offer many treatments without ever asking you what's the most important thing in your life, what are you willing to sacrifice and what are you not willing to sacrifice in the course of care along the way. So I think it can take us down a road of conflict or suffering.
It's a wonderful theme of Atul's book, Being Mortal, this idea that we do need to get doctors, we need to get better at asking people their priorities early on.
Yeah.
But I would disagree that healthcare is becoming unaffordable. That's a political decision.
Is that what it is?
Yeah.
Well, more on that in a minute. But just briefly to touch on this, in your book, you talk about this debate between empathy versus detachment. How empathetic does a doctor need to be? Or does a doctor need to be very detached? He mustn't get too involved in the crisis of the patient.
It's a difficult balance. I had a piece in the International New York Times trying to tease this out recently, trying to say that actually doctors who are too empathetic, doctors that are too compassionate, actually become less effective. And I have worked with doctors like this who become extremely involved with their patients. And it's not that they're ineffective in that role, but they find they can't continue in the role for very long. They get burned out because...
But isn't that what a patient wants? Your kind of personal... Isn't that what we were talking about earlier, where if the doctor takes time with the patient...
But if that doctor then burns out after 5 years and 30 years worth of patients...
Oh, you're replaceable.
Yeah. But I think that there is a balance. I mean, the word compassion, it means together suffering with, imagining the suffering of someone else, entering into the mind of someone else's pain. And to do that, I mean, I see 40 people a day. So to imagine, enter the minds of another's pain 40 times a day can be absolutely exhausting. And it would provoke a nervous breakdown in a lot of people. But to have no empathy is worse. Of course, you end up with doctors who are extraordinarily brusque. We were talking about this earlier, who don't even look at you, start writing a prescription as you walk in the door.
That's what happens in Sri Lanka.
So
I can safely say this here.
I do think we need a balance, and it's the old Greek idea of virtue, I think, is a much better one than the Christian kind of idea of virtue, which is that it's something to be aimed at, it's a peak You know, the Greek perspective on virtue is much more that it's always a balance between two extremes. You can have too much of a good thing. And we need compassionate doctors because compassionate doctors imagine our suffering and they would do their best to ease that suffering. But if they get too compassionate, they burn out. And there's something to be said, actually, for the time limit thing. There's something to be said for having time limits on encounters with patients too, because having some kind of a time limit actually makes you get to the nitty-gritty quickly, actually makes you prioritize, and it actually makes you address the problems in a prompt and efficient manner. I mean, 10 minutes is ridiculous. 10 minutes isn't long enough, but an hour is probably too much for many of my patients. So I think we do need some time limits.
Are there time limits in your...
Well, it's heavily dependent on the perspective of the place and time you are. So yes, in Boston, we have a 20-minute visit. You have a 12-minute visit. And then I'm part of a consortium with the World Health Organization, the World Bank, that's been studying primary health care around the world. And in India, the way that one of my colleagues did the study was by sending mystery patients, so sort of like secret shoppers, patients who would give a report of having chest pain or classic symptoms of TB. And they would go to usual sources of care for people across different parts of India. 25,000 of these folks went out. And the average visit in India was 2 minutes long. You would have one question asked of you. There would be one exam element, meaning that they might put the stethoscope on and that's it. There would be half the time not even a clear diagnosis given. When the diagnosis was given, it was often incorrect. And then they would prescribe 2 to 3 medicines, often an antibiotic, a steroid, and a pain reliever, irrelevant to whether it was the correct treatment for it. And there was tremendous distrust and frustration among patients in the system and a feeling of lack of empathy. And I think it's a reason why people then will pay cash to go outside the government system to try to get more time in the private sector, but there isn't higher trust there. So context, I think, matters a great deal. People want time. Most of all, what they want is caring. And you know, one of my colleagues wrote recently, quality in care is love. And that's the hardest thing. And as Gavin says, you know, I've been in a surgery clinic here where we saw in Maharashtra, in a district hospital, 250 patients in 3 hours. So you are just boom, 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 a minute to 2 minutes.
Yeah.
There's no love.
Yeah.
There's no, there is compassion. There is, you know, the doctors cared and they would find ways to get people up the waiting list. And, you know, 2-month waiting list for people with cancer. So, you know, the condition of generating time costs money, but India is a place that has underspent on healthcare. Less than 3% of GDP. Comparable places spend more and have the government more involved and supportive of care. In the US, we spend 20%, and yet we overspend on technology and way undervalue having a relationship and time. We could afford to pay for time, and we're not.
Aarthi, in your book, you give this amazing statistic that there's a kind of drain of doctors from here. There are 47,000 Indian doctors in the States and 25,000 in the UK. So is there some way that the system is failing doctors themselves? I mean, is that why doctors leave?
There's 2 things that I've been told, and one is that the medical education in India is becoming increasingly expensive. So there are public colleges that are very good but highly competitive, so not many people get in there. Or you can go to a private college that costs a fortune. When you look at the salaries that doctors get in the state system or even in private hospitals, it's very low. So the chance that you can pay back your debts or loans or even recoup what you've spent it's not an easy thing to do. If you go abroad, your salaries immediately become much, much higher. And the second thing is that the Indian medical syllabus, all the books, Western texts, they're not written by Indians. The type of medicine that you learn in India refers to diseases, I was told, that generally happen outside of India. And a lot of diseases that happen in India, they're not specifically referring to them. This is acute in the field of psychiatry. my university ran a course in Delhi at the Ram Manohar Lohia Hospital, which is a government hospital. It was a weekend course. It was packed for both days with psychiatrists, psychologists, and social workers. And we went with psychiatrists and anthropologists because the question that those people had, the doctors had, was, can you explain what possession is? What is this possession trance thing? Because our books don't tell us what it is, and our patients come to us and they use those words.
Possessed.
The Devi, the Booth has possessed me. And they may be talking about a range of things, but the doctors don't understand what the patients are saying. So there aren't any psychiatric texts that are written by Indians. No one's done it. So
Is there plans to introduce a system whereby new graduates have to stay for a certain number of years? It's very difficult,
Yes.
isn't it? We're experiencing this in the UK right now because of various attacks in the health service. There's a lot of doctors leaving the UK to go to Australia, and so we're struggling to retain doctors there. And yeah, it's very difficult. These are highly mobile, very intelligent, professional people. It's difficult to say, right, we're going to confiscate your passport. So, yeah,
from what I understand, the Indian government is saying that you can't, if you have a public medical education, you can't leave for a certain number of years.
Right, and well, I mean, my own parents deal with the guilt. You can ask my mom what she thinks about the choices of coming or staying. She was a pediatrician. And I think we have a study underway right now in 120 hospitals in Uttar Pradesh, where I've gotten to know the physicians who are in the public system. The vast majority of them would leave the public system to work in a city private setup if they could. And if they could leave the country to go work in a setup in UK, Australia, US, they would. And the biggest reasons are that it's opportunity, and yes, it's income, but heavily it's frustration. In a public system, dealing with corruption, dealing with inability to get supplies, in spending a substantial portion of your time to make the system work is demoralizing.
So it's the bureaucracy of the system that's
the bureaucracy of the system, and it's the sense that you are not effective, the feeling of not being effective on behalf of the folks that you're having to take care of, and sometimes feeling morally compromised. I think that is an important source of drain. That yes, income plays into it, but I think it's not quite as simple or as crude as that, because there is a lot of spirit and a lot of feeling of wanting to give back and to care for and take care of a lot of people. But when you're in the public clinics and you're a primary physician, you will have a feeling of an empty stock cupboard. You can't provide the medications. You don't have diagnostic equipment that works. You have a difficulty getting laboratory tests. And so the combination of that makes for frustration. A lot of what our own research work is around making the management system work. I'd written my previous book about simple checklists, and what we're doing is having a checklist for childbirth around 30 things that are life-saving, and trying to see if everybody up and down the system, from the pharmacy stock clerk to the supervisor to the physicians and the frontline nurses delivering the babies, whether they can order and make sure that the priorities fall into place. And when you start seeing the death rates drop and you start seeing the system work, the morale and the feeling of function, and that you are not alone, that you're part of a professional culture and a team, is an enormous change.
Being able to get rid of being able to highlight and eliminate corruption would be a huge part of that. People feel a lot more empowered. And I worked for 3 months once in a hospital in Himachal Pradesh, and it was extraordinarily frustrating. We had an ultrasound scanner in the corner, and we weren't allowed to use it because the license to use it involved paying a bribe. And but isn't it? I remember reading in the papers in the UK a while ago. There's this extraordinary website, isn't there, in India called IPaidAbribe.com for highlighting. If you have to pay a bribe, you can put it on this website, and by shining a spotlight on the fact that you had to pay a bribe, that's how it's eliminated. So wonderful. IPaidAbribe.com, something like that.
Ashok, I think equally important as discussing brain drain is the distribution of doctors in India, inside India, because I think it's quite hard to get doctors. In the urban centres,
they're adequate.
Because there are all these figures quoted about how many doctors there are in India for equivalent population, and actually in the urban centres it's not that bad, but in the rural areas it's dire.
So how
It's
can
a global problem.
Yeah.
You know, the reason my parents ended up in the rural part of Ohio is that there were incentives for immigrant physicians to go to rural parts, but others don't want to go because A, the schools are not necessarily good, so you're raising your children in an environment that's hard.
Same in the UK, isn't it?
If you're a professional couple, what is the role for your spouse? You're looking for stimulation, and so it's the world over, whether it's the United States, UK, Eastern Europe, Latin America, the ability to provide services in the rural areas is a constant worry, and you're correct. In the cities, there can even sometimes be oversupply.
One other curious question. Why are there so few psychiatrists in India? Aarthi, you bring this up.
Well,
Is there a reason
my
for this?
psychiatrist colleague says that when he chose psychiatry, people said that he was crazy. Why do you want to work with crazy people? It's sort of a field that's looked down upon within medicine in India. So it doesn't have a good... People aspire to be doctors, but not many people aspire to be psychiatrists here.
I don't know how it is in the US, but in the UK, psychiatry has also traditionally been chronically underfunded. Even in my own district, urban Edinburgh, we struggle. The psychiatrists can't get support staff. They can't recruit people. The waiting lists are long.
Mental health crisis, though, here is really, the mental health crisis in India is substantial. That across the world, 28% of human beings will develop a major psychiatric disorder, severe depression, bipolar conditions, schizophrenia less commonly, and addiction, drug, alcohol addiction. And the infrastructure in India, the education system, public health system, have a very hard time because it ties back to traditional religious views of people having something wrong with them as a human being rather than understanding it as a disease, and also feeling that it's not really treatable. The capacity to begin turning that around, we're just barely at the beginning of addressing the mental health crisis. Suicide is exceedingly high, as people know, but then approaching it less as a crime. And there are people driven to suicide, as we talk about wife burning and things like that. But it is
suicide.
Yes, there's the fundamental driver is depression and an untreated and unmanaged, unacknowledged depression and other conditions.
Right. Now we've talked about certain kind of, I don't want to call them diseases, but certain complaints that exist in the East, such as possession, as you talked about, which don't really exist in the West. Now, there are a couple of, again, complaints or disease, you can't call them diseases, but conditions that exist in the West, as in that don't exist here. DSH. Would you like to kind of just briefly touch on that? We talked about it earlier.
Yeah, DSH is a kind of one of these medical acronyms for deliberate self-harm. So people who cut themselves usually, and it's it can reach epidemic proportions in places, and it's a very, very challenging problem to treat as a doctor when people begin to use cutting themselves as a way of releasing their anguish. A lot of people, especially a lot of adolescent people, are experiencing extreme anguish because of the various tensions and challenges to do with their roles, growing up, finding an adult identity, peer pressures. And when that anguish reaches a pitch where it needs to be expressed, sometimes people begin to cut. And I see hundreds and hundreds of people who cut themselves. And you're telling me that it doesn't exist in India. People don't do it in India.
Why does it not? Or I'm not saying it doesn't exist, but it is less known.
I'm anxious even about talking about it because it's a well-known phenomenon. For example, in the city where I practice, certain schools have clusters of it. So adolescent girls who start to do it, it seems to be infectious. So they hear about it. They know about the possibility. Oh, why would you do that? So then they start to do it. Just similar, anorexia. There's clusters of anorexia in certain schools, but not in other schools.
Yeah,
but my colleagues studied looking at the rates at which what's called that cutting behavior, often young women cutting their wrists and other parts of their body in a suicidal gesture, and looked at across many countries in emergency room records of whether they turn up. And as the psychiatric infrastructure and mental health infrastructure strengthen, you start to see larger numbers. And so there's two thoughts about it. Number one is that you begin to have in more affluent societies access to mental health care. And for people who are very on the edge, they're viable and functional, but may have a lot of conflict with their families. They have a psychiatrist or a peer group to fall back on, and they are demonstrating and acting out in ways that turn up in this particular way. But it's definitely tied into the sense that you hear about other people who are doing it and begin to imagine it for yourselves. Another one is anorexia,
Yes,
which is starting to appear in India,
Which is a kind of TSH,
in urban populations and young women. And so it's tied into self-image, tied into the way that the culture holds up ideas of what people are to be, and into family conflicts.
But why is this sort of correlation with kind of wealth and higher standards of living? And because you would expect it to be the other way around. You would expect sort of a place where conditions or in your personal life are dire, that might drive you to suicide or anorexia or self-harm. But it seems to be the other way around. It seems to be more...
You know, it's well documented that you once you have a basic minimum income, there is no correlation between your wealth and your happiness. So, and my practice is in a place where I have phenomenally wealthy patients and patients who are phenomenally unwealthy. It's an extraordinarily mixed area. And yes, definitely the rich people are no happier than the poor people once the poor people have enough. And the tensions that some of these young people are under in terms of their parental expectations and the expectations of them academically are enormous, far more than the tensions that are placed upon the parents of those who are less well-to-do.
Okay.
And so, although you'd think that everything was going well for these teenage kids, actually they're in an extraordinarily pressurized environment where both their parents are extremely high-functioning, they've both often got professional jobs, there's an expectation that they will do the same, and then they're going through that kind of adolescent rebellion that many teenagers go through. And what do you do when you're trying to rebel in that system? I don't know, it's a very, very difficult problem. And as I said, I'm anxious even talking about it because it's been shown talking about it increases the use of it.
But I think it's worth just to highlight one thing, which you're saying here. Below a certain level of wealth, depression is high, stress is extraordinarily high. You're likely to develop cardiovascular disease, hypertension, strokes at a much younger age. You know, I see cancers here appearing 10, 15 years younger than in other places where I practice. And it has to do, I think, partly with environment, but heavily with the degree of stress that people who are tremendously impoverished face. But then above that level, you get to have the freedom to have conditions like anorexia and other conditions that are just not even part of the world of worry about self-image when you barely can put food on the table.
Okay, so they're sort of kind of luxury diseases, if you like. Let's move on to something that everyone suffers from, death. Let's talk about death, because it seems to me that there's a huge difference in the way the West looks at or towards death and the way that East looks at it. Would any of you like to jump in on this one?
Well, I think Atul's the right person for this.
I'll start in. My most recent book, Being Mortal, is trying to tease this apart. And part of what I came to the view of is it isn't the classic East. Yes, I didn't bring the copy. I should have brought my copy.
Yeah. Being Mortal.
Is East, West. It's less a distinction than the distinction between agricultural versus industrialized society. That in an agricultural society you have the extended family. The extended family takes care of you through the phases of your life. Looks after you. My grandfather, I wrote about him. He died at 108 in my father's village with people surrounding him. Oh, thank you. There it is.
And if I can just interrupt, this is Gavin's book.
Yes.
Aarthi has a book coming out in March.
It's coming out in May. It's called
The Bone Setters.
In the Bone Setters Waiting Room, Travels Through Indian Medicine.
In the Bone
All
Setters
very
Waiting Room.
cheering books, these are.
That's right.
No, Atul's is a cheering book. I recommend it to everybody.
By the end. So the perspective was that growing old was not something to be afraid of. You were not leaving your home. He would sit at the head of the table. He would be honored as still the person you would turn to for business advice, for marital choices. Even as his memory was fading, people would pretend to bring their choices to him. and it was a place of honor. It was venerated. By contrast, my wife's grandmother, my wife is in Virginia. Her family's from Virginia, and she died in a nursing home with no family around, miserable for the last couple years of her life. And the view of it was that dying was a medical problem. She would be taken from doctor to doctor. Can you fix this? Can you fix that? And of course, what she was dying of was old age. And there was always a new condition, a new problem with her blood pressure, a broken hip, this or that. But no one who understood the question that my grandfather got to answer: what does it mean to have a good day today? How can I do it best? You know, for him, for example, he always loved to walk his 200 acres of fields. And so he would ride on a horse. Well, the horse was too dangerous for him by the time he was 108. So they got a smaller horse. And you'd be sat on the horse, and they would walk around on the fields, and he would get to do that. Now, why did that work? It was because it was dependent on the enslavement of young people, especially the young women in the family. It was the daughters-in-law, the granddaughters. And Indian progress has come from giving young people freedom. Freedom to live where they want, marry whom they want, work where they want. And that's a classic tension. It was a tension America went through and Europe went through in the 19th century. We're going through now. The prosperity of India is all these people moving to the cities and feeling tremendous guilt about the family left behind. And the result is we're replicating the same thing. We now have them go see the doctor. In the cities in India, most people die in the hospital now, behind the curtains in a very medicalized experience, and it looks more and more like what it looked like for Alice, my wife's grandmother, rather than what it looked like for my grandfather. And trying to make a mixed world, as my father died from a brain tumor, was what we were trying to figure out how to do.
One of the very interesting things I thought you discussed very well, Atul, is the idea, though, that when given the choice, a lot of elderly Indian people wish to live independently from their children. And more and more, so retirement communities are springing up in India, and the possibility of just seeing their kids on the weekend, their grandchildren on the weekend, is actually very appealing. Because in the West, there's very much guilt about this, saying, no, we shouldn't have these ghettos of elderly people, everybody should be integrated in the community. And it was interesting to see in your book, you said a lot of the people you spoke to said, well, no, actually, that's what they want.
Yeah, so the interesting thing is, as prosperity comes and you can give people pensions and the elderly get financial choices, they do not want to move into their daughter or son's home and live under their rules. They want their daughter and son to live in their house under their rules, and they don't want to live there. And people end up choosing, if they have the financial means, to live at what the sociologists call an intimate distance, near but not too near.
Yeah.
And that tension, I suspect many of you feel playing out through your families. Whose rules are people going to live under? And until you have the economic means, that's where the battle occurs.
In Scotland, they say you should always have to put your coat on. So to go and visit your parents, you should always have to put your coat on. So it should be close, but not too close.
I think this is why Chetan Bhagat is such a popular author. Think about what Chetan Bhagat's novels are about. They're about the son, or usually the son, going to the city, making it in a call center or in a consulting firm or some business, falling in love with the wrong woman, and then having to figure out how do you deal with the family, the aging parents, and what's going to happen. Yeah. And invariably, what makes people want to buy the book, the guy always has sex with the girl at some point in the book, and the family is still happy at the very end, nonetheless.
Go back to what you're saying about the 19th century as well. We were discussing this before. There's an undertaker writer called Tom Lynch who writes beautiful essays about death. And in the West, we are getting better at talking about death. And he always makes the distinction that in the 19th century, people had extraordinarily public deaths and public funerals, but extremely private sex. but now they have public sex and private funerals. and so we need to get the public, we need to raise awareness that it's all right to talk about death in the West. It's all right to say, increasingly I say to my patients when very soon after they've had a diagnosis of metastatic cancer, I'll say to them, where do you want to die? And it's a very shocking thing to bring up early in a relationship, which I'm going to have with somebody visiting them perhaps weekly for several months until they die. But it's extremely useful to know that right at the outset. Are we going to be planning, as we can in the UK, to have community nurses coming in and out of the house? Or are they going to say right early on, no, I don't want that. I don't want my family having to deal with that. And we have to respect that choice too. Death is, it can be, the caring roles that you put on the family can be too much. And sometimes, particularly if people have had very abusive experiences of upbringings in family, and we expect family members to take on that caring role when somebody becomes terminally ill. They might have to care for somebody who beat them as a child, So it's a minefield, and we have to explore it early. And talking about it, books like Atul's raise the conversation. Let us talk about it early.
Aarthi, do you want to add to this?
I just wanted to say something about death and autopsy and cause of death, because I think in rural areas, again, because you don't have the doctors and you don't have the dying at home with their families, good, but I don't think it's really widely been looked at why they died or the causes of death. And so I met in Gadchiroli, in forests in Maharashtra, I met two really amazing doctors called Rani and Abhay Bang, and they've set up a hospital with their own money for tribal people, Gawande tribes. And their work's interesting for several reasons, because they talk to the tribes and they ask them what this hospital should look like. The tribes said there should be, at the gate, there should be a temple of their goddess. That was one of the first things they said. But they also said some interesting things about their perception of, which told you about the perception of medicine and conventional doctors. They said the hospital should be one story, should be close to the ground because the earth is our mother. And they said that when we go to the hospital, doctors wear white coats. We wrap our dead in white. We don't trust them, we're scared of them. And so they implemented, and all the hospital buildings look like tribal huts. The place they dispense medicine and public health advice looks like a gotkul, which is where a community center where people meet and girls pick their husbands, because that part of their life is matriarchal until they get married, and then they don't have any control. But these doctors have a research facility there too, and one of the huts in the jungle is a hut for computer scientists and statisticians. And so they've gone out into the tribal villages and started looking at the diseases that people get and the causes of their death. And they found that stroke was the biggest killer. And it was what you were saying about non-communicable diseases, so lifestyle diseases and stress and poverty. They're poor. I mean, they're kind of hunter-gatherers still, so they do get nutrition, but they don't have money. But she's finding the same things, diabetes, hypertension, stroke. So it's very interesting to try and because these are people who walk. They're getting more motorcycles. They used to walk miles or cycle. So you are seeing lifestyle changes, and also keeping up with the Joneses. They're getting a bit competitive, and there's stress associated with getting a bit wealthier. But it's interesting to see why people who we would think have a healthy lifestyle and don't eat large quantities of food get similar diseases.
Still get the same.
Yes.
Okay, time now for some questions. Gosh, lots of questions. Let's start at the front row here, lady in the front there.
Hi, morning. I feel in India, the interaction with the doctor is like the blind man and the elephant kind of story, wherein, one, you're so petrified to ask a question, and the second is the specialization of the doctor, and the doctor who's expert in his field would like to be asked a question only pertaining to his field and no other nonsense he wants, because the doctors are in a hurry. So it is just because that we are too large a population in India, or you feel there's any other reason to it?
Well, I think there are two things. Number one is exactly as you say, people tend to go to the specialist, guessing what the diagnosis is, and then that specialist just says, well, you must go to someone else if you want to worry about this. This is your problem. I'm the gastroenterologist, so let me put a scope in it. But the primary physician, the general physician, is often distrusted in India. How do you know? You don't know enough. How can you know what there is? And that concept of having a usual source of care, someone who knows you, someone who connects you into the system. So the concept of a system of care where you have a generalist, almost like a contractor, who knows you through your life, connects you to the right people to help you. When they don't help you, calls them up, says, now wait a minute, you know, what are we trying to put together here? Trying to create that concept of what we've called the 4 C's, that you have a point of first contact access, your usual source of care. They have continuity, they know you over time, that they will coordinate for you, and will provide comprehensiveness. They will address the majority of your needs and know how to get it in. Creating that, I suspect you find that very hard to find, that person. All I can tell you is it is very hard to find in many parts of the world. The UK has done an amazing job at creating people like Gavin who sit in that system. And Aarthi probably can tell us a little bit about why, of all places, India had a tremendous British influence, but did not keep that generalist physician concept. And it got lost somewhere there. We don't have it in the US, and we need it.
The UK only came in 1948, you know, and it's, as I alluded to earlier, it's very much under attack just now, but it's the reason why the UK NHS was rated number 1 out of 20 developed world healthcare systems in terms of its efficiency and its cheapness, because, you know, most of the people who come to me with headaches have tension headaches or sinus pain. Maybe some of them have migraine. Maybe every 5 years I might see somebody who turns out to have a brain tumor. But if you go and see a neurologist with your headache, they're immediately going to scan you, find all sorts of anomalies. Generally, they create more anxiety. And having somebody who's trained enough to be able to exclude the serious causes is a very, very efficient way of doing it. And so I've got very quick access to neurologists when I see people with unusual headache, but I can handle most of them. Yeah.
Okay, there's a question at the back, guy in the red scarf. Who's
red scarf standing up?
Red scarf. Lots of questions, so we'll try and keep our questions short and our answers short.
Hello, sir. This is Rupesh. My question is, anyone who will want to give answer. Whenever I have headache, instead of going to drugs, I chant Omkara, and it really works. So, do you think it's time to really go towards east? My question is this.
Well, I believe that most minor self-limiting health problems have an extraordinary influence back and forward on your state of mind. And so this is part of the stuff that we threw out in the Renaissance and we're only just discovering again. That of course, you know, your mind and your body, there was no distinction. The two are the same. You know, if you drop a brick on your toe, your entire conscious energy of your body is in your toe for the next few seconds. The two are very interlinked, and your state of mind affects the way you feel about pain. So if doing that makes you feel better, I think, of course, it's going to cure most of your headaches. But sometimes it won't, and sometimes people do get brain tumors. Not very often, but they do.
Can I just say something about
sure.
evidence? Because the other question I had is evidence important at all? In Western science or system of medicine, there is a process whereby you do research on a certain number of a certain population size, and you test it and you publish it, and it's criticized and retried. And that's a system. And from my visits to Ayurvedic research centers, even the Unani research centers, they're trying to replicate that model using the traditional systems of medicine and trying to test them using Western clinical trials. It's not easily superimposable, but when you say, I have a headache and I chant Om and that helps me, great. Let's test that on a large group of people and see if that still holds true. And then you can say maybe there's something that we can apply more widely. I mean, that's how Western medicine works.
There's a question here.
Yeah. So my question is on the plurality of medical paradigms. So what we all talked about right now was essentially the allopathic paradigm and its limitations in terms of when people should not be treated with it. But we really didn't question what's not working in this paradigm, which is essentially a biochemical view. while Eastern medications are all beyond biochemical view, and they look at an energy view or a different paradigm altogether. So have any of you explored anything beyond allopathic paradigm and seen how that works more effectively or differently for diseases which allopathy really just can't do anything about?
Well, that's what I was saying. Then there are now a lot of studies going on to try and see how these medicines are working. But the way they're looking at it is using the language of biomedicine. They're trying to understand, say, Ayurveda, using chemical and genetic analysis of the herbal medications. So the reason they're doing that is because patients come to Ayurvedic doctors and they're using biomedical language. They're saying, this is my blood pressure, this is my blood sugar level. They want it to be interpretable. So there are lots of studies going on to try and understand why these medicines work at the moment. So watch this space.
Just to tie into that, part of the conflict is that if you go to a massage therapist or a herbal healer or an Ayurvedic physician and you put 7 in a room, they cannot agree on what the treatment should be. And trying to say, yes, this is what Ayurvedic means, and this is what we would have as, proof means that you all do the same thing, and let's have that as a protocol. We will have 1,000 Ayurvedic physicians testing treatment of a particular condition. Let's say it's arthritis and back pain. When people have done that, and people have found ways to do that. So for example, acupuncture has now been very well tested, and there is some agreement on what the meridian lines are and the chi that you're trying to bring out. And it's been proven to be effective very narrowly around certain kinds of pain that are often very difficult for general medicine, allopathic medicine to treat. And including having sham needles. There are needles now manufactured that don't penetrate the skin as deeply, and the patient can't tell the difference, and so you really know whether it's making a difference or not. And there have been narrow spaces where it's turned out to make a difference. But the sense that it's either or, and there's a wellspring of, there are cancer treatments we didn't know about, blood pressure treatments we didn't know about, so far that hasn't blossomed in the same way.
So back to what you said about what I mentioned earlier about Freud and the factor of the therapist. And we have this in Western psychiatry all the time. There's a whole load of different systems and theories by which you can deliver counseling therapies. And when they try and test them and see which kind of counseling is the best, they find it makes no difference actually which kind of counseling you get. What matters is the therapist, the counselor.
And that you have counseling.
Yeah, but it's the individual. There's a charismatic element of a therapeutic encounter with an individual who is good at it, and whether they do CBT or whether they do whatever type of counseling, you'll get better if you see that person.
Right. Yeah. They can convey caring.
Yeah.
I'm sorry, there are lots of questions. This gentleman here has been waiting a long time. So
my question is to Dr. Gawande, really.
Where are you?
Oh, there you are. In a context where the physician is considered less than sexy by corporate medicine, and where the race is towards the specialist, who's the superstar, and that's where the big salary packages go, and then of course those salary packages have to be validated because then the labs have to be kept running, and in corporate medicine we've also have scenarios where managements post people then say, doctor, we're not getting enough tests, would you need some assistance? In an atmosphere like that, the average patient is going to the hospital system always looking for a recommendation because that's his only assurance. Do you know so-and-so? How does the average patient protect himself from this corporatization of medicine? Because quite obviously the medical council reports have told us that 2 minutes is not adequate. That there is a holistic look which the good old NHS, the physician over long-term acquaintance who knows you and treats you holistically and understands that the back pain might be more psychological than physiological. How do you protect yourself in this rapidly corporatizing, even mercenary environment?
Well, it's right now, I often tell in the political debates in the United States that the conservatives in the United States want to have a world where there are no regulations, where people are paying cash rather than having insurance. And I tell them, go visit India. It is the libertarian conservative dream, right? It is a completely unregulated system. You can walk into a pharmacy, get any drug you want, be uncertain whether that is a drug that actually is what it says in the pill. You can go to the specialist and they will charge you exactly however much they say, and they may or may not tell you what they're doing to you. And it is buyer beware. And the reality is that in medicine, when you are a buyer and the seller knows more about what they're giving you by far than you know, and it's behind a curtain, and it's behind the language, and it's behind all of those things, you are defenseless. Now, transparency goes very far. So the ability to know more about people's reputation and allow there to be some transparency would be an important help. It's inevitable that there has to be some professional regulation and a strong system of both professional culture and excellence, and the demand that the profession be driving towards the higher standards, and that the aspects of corruption that are present in systems all over the world, but are especially deep here, that they be the target of even journalism and other areas. Because I don't think you can easily shop around. Your best avenue right now is reputation. You do your best to find people who are trusted, people who are likely to be faithful to you, acknowledge when they make mistakes, stick with you along the way, are gentle, kind, and add some time. But you are in an uphill battle where you have a system that does not remove a license if someone is behaving very poorly or even exploiting patients along the way. So there's, I think it is a appropriate fear that you're not able to find folks. In the US too, we're in the same way. Your best result is to count on a colleague. Our best measure in the United States in surgery is turning out to be, if we ask the staff, would you recommend your family member have surgery in your own operating room? And it varies from 30%, only 30%, 70% say no, all the way up to 100%. And it correlates with what the survival rates are. So to the extent you can, you ask a nurse, would you recommend that you go see this doctor, or would you recommend not?
And on that rather depressing note,
Yes.
I have to close everything. I'm sorry, there are lots of questions to ask. Buy their books, chat to them afterwards. Thank you very much indeed.
Thank you, Ashok.
I know you have a lot of questions.